In this video, I'll be discussing the imaging differential diagnosis of granulomatosis, polyangiitis, and sarcoidosis. In the previous video, we compared these two entities and talked about their specific imaging findings. This is part 14.2c in an approach to chronic dyspnea. This video will cover the following topics. First, we'll talk about imaging findings in pulmonary tuberculosis and how they can mimic those in GPA and sarcoidosis. Under this broad heading, we'll try to understand the pathomechanism behind pulmonary tuberculosis, understand how these translate into imaging findings of pulmonary tuberculosis, distinguish between two important concepts in tuberculosis that are often conflated, namely the role of the immune status of the patient in determining clinico-radiological presentation, and two, the concept of primary versus post-primary or secondary tuberculosis. We'll understand why pulmonary tuberculosis then thus mimic both granulomatosis with polyangiitis and sarcoidosis. Finally, we'll understand why this differentiating DP from isolated GPA or sarcoidosis becomes relatively straightforward in most clinical scenarios. We'll end with a brief discussion on angiocentric granulomatous lung lesions. So naturally, we'll compare GPA imaging findings to those with lymphomas with an angiocentric nature. We had used T follicular helper lymphoma angioimmunoblastic as an example in the part 14.2a in this series. So we'll continue with the same. And then we'll talk about lymphomatoid granulomatosis. So epidemiologically speaking, lesions that show an angiocentric involvement as described for granulomatosis with polyangiitis are actually much more likely to be tuberculosis and solid malignancies. When considering GPA, therefore, it is always reasonable to rule out tuberculosis in India. Similarly, when considering sarcoidosis, it is always reasonable to exercise a high degree of suspicion for tuberculosis, at least in India. With that disclaimer out of the way, there are some imaging findings that can cause confusion with GPA and sarcoidosis, but strongly suggest tuberculosis. But in order to understand what those findings are and how they are to be interpreted, we need to understand the pathomechanisms that underlie the clinical and imaging findings in pulmonary tuberculosis. So we have a innate immune receptor, a specific C-type lectin receptor called DC sign, which is central to the immunological response to M. tuberculosis. The pathogen is, once it is inhaled and reaches the lungs, is phagocytosed by pulmonary macrophages. It has evolved to activate DC sign, which being a C-type lectin receptor can have both an immunoactivatory or immunomodulatory signaling. DC sign particularly actually has an immunomodulatory signaling. As a result of this, two outcomes can happen. One is that the macrophage successfully phagocytoses and kills the pathogen, that is MTB. The other is that the pathogen is able to inhibit its own killing through activation of DC sign and through other mechanisms, which we'll get into once we talk about MTB in detail, and persists within the macrophage. Now, depending on the immunological response to tuberculosis, that is how much interleukin 12 and TNF alpha is produced, we may have two particular responses. So let's get into the details of this a little bit further. So here we have an antigen presenting cell, but obviously naturally a dendritic cell or a macrophage, and it determines T cell polarization. So this antigen presenting cell has detected a pathogen associated molecular pattern or a damage associated molecular pattern that has activated TLR2 and 4 in this particular situation. That causes signaling within the cell, within the antigen presenting cell, which increases expression of interleukin 12. This interleukin 12 is then secreted by the cell and goes and attaches to its receptor on surrounding T cells. Simultaneously, this antigen presenting cell has phagocytosed M. tuberculosis and is presenting some antigen that is expressed by MTB attached to MHC class 1 or MHC class 2 to this T cell. Let's say this is a CD4 T plus T cell. So this is in the context of MHC class 2. The T cell detects it using its T cell receptor. The combination of interleukin 12 signaling and detection of the pathogen via the TCR results in the T cell producing interferon gamma. This interferon gamma is secreted by this T cell and goes and attaches to its receptor, again located on the antigen presenting cell. This produces a positive feedback loop which increases the expression of Tbet and decreases the expression of GATA3 in both the antigen presenting cell and the T cell. I have not shown it in the T cell here because there's not enough space. And that in turn results in increased TNF alpha production. So this is essentially the process of granulomatous responses. Let's see how that is different in TB. So I have drawn a bunch of antigen presenting cells interacting with Th1 cells and some of them interacting with CD8 plus T cells. Or Th1 cells are naturally a type of CD4 plus helper T cell. Surrounding this, there is an infiltrate of T helper type 2 cells that are formed, and we'll discuss that this happens later on during granuloma resolution as the body is trying to wall off this granuloma. And these Th2 cells at the periphery activate fibroblasts, which then lay down collagen, resulting in the formation of a typical granuloma. Now, some of these antigen presenting cells can then fuse together to form giant cells, and this entity itself is then called a quote unquote tuberculoid granuloma. Sometimes the fusion produces a very specific type of giant cell which is called a Langhans giant cell, and we'll talk about the morphological features of this later in detail in our sections on clinical immunology and rheumatology. So either way, what is termed histopathologically as a tuberculoid granuloma is actually a spectrum of histopathological patterns. One is a discrete granuloma without any giant cells. Second is a discrete granuloma with a foreign body giant cell. So this is a foreign body giant cell. And the third is a discrete granuloma with a Langhans giant cell. But all of these are characterized by the presence of a dense lymphocytic infiltrate around a closed ring of macrophages, which may or may not fuse to form multinucleate giant cells. This is in contradistinction to what you see in sarcoidosis. Similarly, there is significant surrounding perilesional fibrosis. In sarcoidosis, the granuloma is replaced by fibrosis, not necessarily surrounded by fibrosis in most situations. So in this diagram, we know that if there is a robust interleukin 12 TNF alpha response, you end up getting these granulomata. Now, if the response is not particularly robust, what ends up happening is that now we have a lot of these alveolar macrophages and dendritic cells and tissue infiltrating macrophages that have been infected by the pathogen. Now, these cells are killed by CD8 plus T cells that are in turn activated by interferon gamma production. And that is what is called the tissue damaging response, more colloquially termed the caseous necrosis that you get in tuberculosis. But again, this is a histopathological finding. So, a tissue damaging response, quote unquote, to infection by M. tuberculosis results in the formation of central caseous necrosis. Please note that the granulomata have undergone caseous necrosis in the center. You have a dense lymphocytic infiltrate around it. You may still have some giant cells, or you may develop secondary giant cells, particularly a type of giant cell called a Teuton body giant cell, which contains a lipid vacuole, because obviously there is caseous necrosis in the center. Caseous meaning like cheese, because it is lipid rich, and there is surrounding fibrosis. So we have a fibroproliferative response with cavitation, okay, at the cellular or tissue level. A tissue damaging response therefore does not imply the presence of a weak or immunocompromised immune system. It just implies a delayed but importantly still robust immune response. This is actually what the organism, that is M. tuberculosis, has evolved to do. See, manipulating the human immune system in this way gives M. tuberculosis a survival advantage. Such necrotic material gets expectorated as cough, and that is the only way that MTB, once it has infected a human host, can go to another human host. So it has a selective survival advantage in doing this. So at least in a certain subset of the human population, TC sign activation and therefore a delayed formation of granuloma with secondary tissue damaging responses due to robust CD8 plus T cell activation results in what we call active pulmonary tuberculosis. That does not mean that the patient is immunocompromised. Now, imaging findings in tuberculosis does depend on the patient's immunological response to the pathogen, which naturally is a function of the patient's immunological status. So here I have drawn two types of findings on the right and the left. The first, or to the right of the screen, is the findings that you get in an immunocompromised patient. So this is most common in children because their immune responses are not fully developed and trained. There are three findings that are commonly seen. The first is mediastinal lymphadenopathy that I have drawn in green. Typically unilateral or isolated anterior and posterior mediastinal lymphadenopathy, again in contradistinction to what we see in sarcoidosis. Next, we have lower lobe consolidation, that is this. And third, we have a pleural effusion, which I've drawn in yellow. On the other hand, in an immunocompetent patient, please remember this is a normal immunocompetent human being, but it is a subset of human beings who, because of the variation that exists in human populations in immune responses, tend to have a delayed response to tuberculosis in terms of formation of granulomata, and therefore the macrophages that accumulate need to be killed secondarily by CD8 plus T cells. This is the response that occurs most commonly in adults. This is what we call typical fibroproliferative active disease. So this presents with upper lobe consolidation with cavitation within the upper lobe. Now importantly, the size of the lesion does not correlate with risk of cavitation. Very small lesions can undergo cavitation. And there is secondary surrounding fibrosis. In this situation, contrary to classical teaching, if you understand the immunological pathogenesis in detail, what you understand is that actually the immune system here is struggling to contain the spread of the pathogen, and that is why you have all of this. Yes, pleural effusion is still extrapulmonary tuberculosis, but it's not that an appropriate immune response has developed. That is why there is a pleural effusion. It's that the response is not adequate to control the pathogen. This is, however, different from what happens with very immunocompromised patients and the development of miliary tuberculosis or disseminated tuberculosis. So there is a distinction between the two. On the other hand, here we have actually an immunocompetent patient in whom the immune system has been manipulated by M. tuberculosis, resulting in a delay in granuloma formation, but eventual granuloma formation and eventual robust CD8 plus T cell tissue damaging responses. So I hope that much is clear. Now coming to a unrelated but often conflated concept 2, that is what is primary versus post-primary tuberculosis. So primary pulmonary TB and post-primary pulmonary TB are terms that refer to the pathway taken by a patient who has developed an active infection. So this refers to the natural history of disease. So let me explain. Once you have exposure to tubercular pathogens in the environment, there are two possible outcomes. One is that the immune system is able to clear off the pathogen. This happens in 90% of adult humans. In the remaining 10%, the pathogen persists. It has not been completely killed off. So two possible forms of infection then develop. The first is what is called asymptomatic or latent or inactive tuberculosis, which is actually the far more common form. The second is what we call symptomatic or active tuberculosis. It need not be symptomatic, it may be just active radiologically, but often and usually is. Patients can go from this pool of patients to this pool of patients, that is from latent TB to active TB. This pathway, that is direct infection and development of symptomatic active TB, I'll label it as pathway 1, and this is what is typically called primary pulmonary tuberculosis. Pathway 2, that is infection followed by latent phase followed by reactivation, is what is called post-primary TB or secondary TB. The pathway 2 naturally does imply that there has been a secondary immunosuppression. So post-pulmonary TB does imply that at some point in the natural history of disease in the patient, there was immunosuppression. That is, the patient became secondarily immunocompromised. So now how are these two concepts related to one another? Imaging findings can predict the patient's underlying immune status in pulmonary tuberculosis. Yes, they can, as I've just discussed. Development of secondary or post-pulmonary tuberculosis is indicative of the development of an immunocompromised state. Yes, again, that is true. So imaging findings that suggest an immunocompromised state are those that are found in secondary or post-pulmonary tuberculosis? Actually, no, because again, it's inappropriate usage of a term that is meant to imply the clinical or natural history of the patient's disease being juxtaposed onto a phenotype that reflects the immune response rather than the immune status of the patient directly. So again, primary versus post-primary tuberculosis are terms that refer to presumed natural history of disease in a particular patient. No imaging findings can reliably differentiate between these two entities, and this has been actually proven without a doubt. The reference is there. Older literature does use the term primary and post-primary in the context of imaging and supposed underlying immune status. But as you can see, the findings that I have described in quote unquote robust immune response is what was previously considered the findings that happen in an immunocompromised patient. So as I have just demonstrated, that is not true. And the findings that were supposed to previously represent a good immune response, that is mediastinal lymphadenopathy, extra pleural effusion, those actually represent an immune system that is responding to the pathogen but is actually struggling to catch up to the pathogen because it is not been exposed to the pathogen previously or is otherwise immature. So it's really not appropriate to use such terms as primary and post-primary TB in the context of imaging, because the immune response is rather complicated and there's a lot of nuance to it. Okay, so traditionally, as I've just said, the findings here have been said to represent a poor immune response. This does not represent post-primary tuberculosis because it does not represent a poor immune response. Again, I have just demonstrated this. In fact, it actually represents a normal immune response in a subset of the population of human beings who are at increased risk of developing tuberculosis because they just happen to have increased DC sign signaling or develop granulomata in a slightly delayed state, allowing for the pathogen to divide more rapidly. Now, that could be a genetic thing. It could be because of transient immunological ineffectiveness in that patient. So this is the normal response of a healthy immune system to the pathogen. This is what the pathogen wants to happen. On the other hand, to the right of the screen, we have an immunocompromised patient developing three findings. That is mediastinal lymphadenopathy, low lobe consolidation, and pleural effusion. This is actually traditionally thought to represent a robust response to tuberculosis. And again, as I've just shown, that is an artifact of a rudimentary understanding of the immune system. This does not represent primary tuberculosis because it just does not represent a robust response to the pathogen. On the contrary, it actually represents an immune system that is being unable to contain the pathogen adequately. These two imaging findings correlate with the type of immune response and not the pathway taken in the natural history of the disease of the patient. Okay, it is the type of immune response. Again, the terms immunocompromised and immunocompetent are very large umbrella terms that are best not used unless in the context of somebody who has been taking immunosuppressive medications clinically. Okay, thus imaging does reflect the immune response, but imaging does not differentiate between primary versus post-primary tuberculosis. This distinction, if it is to be made, can only be made clinically. And please don't get confused between these two concepts. Imaging findings in pulmonary tuberculosis can mimic those of GPA and Sarcoidosis. Naturally, the findings that happen in a normal immunocompetent adult patient can represent those in granulomatosis polyangiitis. Again, we can develop consolidation, we can have cavitation in GPA if the lesion is large. Similarly, mediastinal lymphadenopathy and a lower lobe consolidation could represent sarcoidosis, although at least mediastinal lymphadenopathy definitely could represent sarcoidosis. However, there are clear holes in this story. One, in case of GPA, upper lobe involvement is very odd. Why is it upper lobe? Second, cavitations developing in small lesions in GPA are unusual. As I've discussed in the previous video, 25% of lesions larger than 2 centimeters undergo cavitation. So the larger the lesion, the more likely it is to cavitate. Lesions in GPA resolve without scarring. So again, the presence of fibrosis here is very odd for GPA. Similarly, in case of sarcoidosis, the type of mediastinal lymphadenopathy is odd because it should be symmetric. There should not be significant asymmetry. It cannot be isolated mediastinal lymphadenopathy. Two, lower lobe involvement is again odd. Again, sarcoidosis tends to affect the upper lobes. Third, the presence of a pleural effusion is in itself odd for sarcoidosis. So these are cases that are much more likely to be suggestive of active TB than GPA because one, as you can see here, there is primarily upper lobe involvement. Two, a relatively small lesion here, you can see it is smaller than the vertebral body's anteroposterior length, has developed a cavitation, again very odd for GPA. And in this CT scan at the bottom, there is obvious fibrosis, which is very unusual for GPA. If you find any of these three things, it is TB. There may be coexistence GPA, but there is definitely TB. Thus, actually, TB can be differentiated relatively easily from both GPA and sarcoidosis if you understand things reasonably well. So, in case of other angiocentric granulomatous lung disorders, we have TFH lymphoma angioimmunoblastic, which we used as a representative example, and we have lymphomatoid granulomatosis. So, as I've discussed previously, these are the findings that we have in GPA. Now, let's see which of these findings and in what form can also happen in a angiocentric lymphoma or lymphomatoid granulomatosis. So, nodules in GPA tend to be random in size and distribution, and they are multiple and fleeting. So, this can happen with angioimmunoblastic T cell lymphoma. Again, that can also happen with lymphomatoid granulomatosis, but these nodules tend to conglomerate, and that is a little odd for GPA. Bilateral consolidation and granular opacities, a combination of the two, is common in GPA, accounting for almost 50% of patients with GPA, but it is an uncommon finding in either of these two entities and is usually unilateral. The reverse halo sign and the tree and bud findings are uncommon in GPA, whereas they are actually extremely rare in lymphomas. What you actually do get is a lymphangitic spread. If that is present, that is naturally not going to occur in GPA. Finally, hilar lymphadenopathy is very unusual in granulomatosis polyangiitis, but is very common in lymphomas and lymphomatoid granulomatosis. So in lymphomatoid granulomatosis, we have, as you can see in this particular case, multiple large irregularly marginated pulmonary nodules with a basal predominance and prominent asymmetry. So again, the asymmetry is very odd for GPA. These nodules demonstrate two imaging findings. One is some of the nodules are coalescent, that is, they are undergoing conglomeration, and some of them are GGOs. This combination of conglomerated nodules along with some nodules showing GGOs has been termed to represent what is called a migratory phenomenon, which we've also seen in GPA. But again, the asymmetry, the conglomeration, all of that is very odd for GPA. So this is almost definitively lymphomatoid granulomatosis. This patient additionally also had significant mediastinal lymphadenopathy. Thus, an angiocentric lymphoma like TFH lymphoma, angioimmunoblastic, or a lymphoproliferative disorder like lymphomatoid granulomatosis can be essentially indistinguishable from GPA on imaging, except for the mediastinal lymphadenopathy. In such cases, we differentiate them clinically and then based on the presence of mediastinal lymphadenopathy. So, in this video, I've talked about imaging in pulmonary tuberculosis. We've understood the mechanisms behind pulmonary tuberculosis, understood how this translates into imaging findings of pulmonary tuberculosis. We've distinguished the two important concepts in pulmonary tuberculosis, that is the role of immune status in determining the imaging and, in fact, the clinical findings in TB, and what is primary and post-primary TB and why that should not be used as a surrogate term in describing the radiology of TB. We've understood why pulmonary TB can thus mimic both granulomatosis, polyangiitis, and sarcoidosis. We've understood why differentiating TB from GPA and sarcoidosis can actually become quite trivial as long as one knows what is one is looking for. And we've also talked about other angiocentric granulomatous lung lesions and compared them to GPA, that is lymphomas with an angiocentric nature. We use TFH lymphoma angioimmunoblastic as an example, and we've talked about the imaging findings in lymphomatoid granulomatosis. So thank you, and I'll see you in the next video where we talk about for lymphocytic interstitial pneumonia and other pulmonary lymphoid disorders.